All right, we're coming to the end. Just the last few things. I just wanted to make a few comments before we finish up the day. We've heard various things from various people about various tumors that have varying degrees of response, and it depends on the cell type and the antigen and the things that you're doing with the T cells. There's a lot there to unpack. So I invite you all to re-listen to these talks as they get on the KISCO website. And think about things, because we're trying to potentially make this an annual meeting coming up. So we want you to think about how you might want to come back, or other things you might want to hear next year. Anything of the meeting that you thought wasn't gone over enough or could go over more, please let us know, because we'd like to certainly hear your feedback. So some concluding comments. So genetic differences affect the immune response, and they affect immune surveillance and immunotherapy. Cancers are varying degrees of genetic mutation and virtually never share the same immunogenic antigens, interestingly. Individuals have varying HLA types and varying ability to present various tumor antigens differently. Microbiome differences between individuals affect immune response and therapy, and potentially immunosurveillance as well. And different tumor and microenvironments influence the immune system as well. So there's a lot of variability there. In many cases, immune escape of tumors is accompanied by ongoing immune attack, which is too weak to prevail in an equilibrium state. Hence, the checkpoint inhibitors and how they de-escalate the equilibrium and allow the T cells to actually attack. What if there's an immune response, but blocking inhibitors isn't enough to overcome the immune escape? Well, as we've heard, could we collect tumor infiltrating lymphocytes, expand them, return them to regulatory cells? And that's what TILS therapy is all about, as you heard from Dr. Chesney. It works well for the highest mutation rate cancers. It doesn't tend to work as well for the lower mutation rate cancers. So what about these lower antigen and mutation rate situations where TIL isn't enough? In the case of many blood cancers, as everybody well knows, we can replace the immune system with one other of HLA match type in an allotransplant and have an immune response that is sustained and curative in many cases. And so the whole nature of allotransplant is changing over time as well, not only because we've gotten smarter about graft versus host disease, but T cells are going to make a big difference there as well. You guys might have seen this paper from New England Journal last year in which a CD8 targeted CAR was used for the treatment of the lymphoma that the patients had, and also as the conditioning regimen for the transplant. These patients got no standard conditioning and no GVH prophylaxis. They got CD8 CAR alone to suppress their tumor and to get the graft in, and they had high engraftment and long-term response. That's impressive, and a new dawn for how we might do allotransplant going forward. So what about cancers not sensitive to the allo effect, and cancers growing too fast for the allo effect to work, or cancers not responsive to NK or TIL attack? And that's where, of course, the CAR T and the BiTE therapy come in that you've heard so much about today. And that raises the question of all oncologists becoming immunologists as well for the future. Because in addition to making plans for how best to treat patients, we must all be shepherds of the immune response and realize that some things that we do to treat their tumors may set them up for greater or lesser chance at immune response later in their course. And therefore, the timing of things becomes critically important, as well as what you're going to do at each of those time points. We have to think about these things not just in the context of cancer, but in the very unfortunately worrisome context of what is going on in our micro environment and these various insults that may cause problems, such as COVID and other things. We know that patients, for example, with lymphoid tumors, CLL and mantle cell chronic lymphomas have a deficit in vaccine response up front. That gets even worse when we do these manipulations with not just chemotherapy, but immunotherapies as well. So we need to take into account the infection risks for all these strata of things that we do to them. We also know there's these T cell physiology differences between people, and there's exhaustion. There's truly immune exhaustion, as well as other subsets like suppressor cells that make a difference here. As Dr. Chesney said, we're trying to study this, but we don't know it well enough yet. T cell exhaustion is of particular interest, as I mentioned, to tumors like CLL, where the type of T cells that we're collecting for CAR T production and the type of T cells that respond to BiTE therapy just are not as good as they are in other forms of lymphoid tumor and myeloid tumor. Drugs like bendamustine paralyze T cells for up to 6 months after they're given. So Bendamustine, very useful drug in many forms of lymphoma. We have to be very careful how we use that, especially for the higher risk patients who we think might subsequently, over the short order, need CAR T therapy. You want to avoid drugs like this. However, there's evidence that drugs might help in certain circumstances. So there's evidence that cyclophosphamide may deplete suppressor cells and therefore set up a better immune environment, that carboplatin may do better with regard to antigen presentation, that drugs like dacarbazine may alter the microenvironment with regard to cytokine production, and whereas certain platinums disrupt the microenvironment and actually lead to greater immune response. Also, how do we mix together things like checkpoint inhibitors and vaccine therapy with CAR T therapy and all these other things that we're trying to come up with in the future? Finally, I'll leave you with this, which is a paper from Herb Weissman's group on the West Coast. And he's a big stem cell guy, but he did this very interesting study in which he showed that he could take older mice, and as mice age, what happens is there's a myeloid stem cell-derived T cell and a lymphoid-derived T cell, and you can separate them in mice. They have different surface receptors. When he injected antibodies to eliminate the myeloid-derived cells that were accumulating with normal aging in mice, he was able to show that he could recapitulate both the cancer response and the immune response against infectious agents, much like you see in younger mice, just by eliminating that abnormal T cell population that accumulated in the older mice. This suggests that potentially in primates and humans and other animals, there may be a way to look at senescent immune systems, which just by virtue of senescence may be contributing to higher cancer rates and are definitely contributing to difficulties with T cell therapy in cancer, and reverse it. So this separate line of inquiry, separate from all the tumor biology stuff, is a critical thing for us to understand better, to not only make therapy work better, but to help prevent cancer from happening in the first place. Because going back to what we talked about in the beginning, immunosurveillance and the failure of immunosurveillance is what causes many cancers. So understanding that is not only important for therapy, but helping us to prevent this scourge from starting in the first place. So, couple quick comments to finish up. Thank you again for spending some time with us this morning. Really, really appreciate everybody coming out on this not so great day. As a reminder, we have a couple of other meetings coming up. Our next meeting is the 2025 Kentucky Annual Issues Conference. These are political issues of importance for cancer centers in Kentucky. It'll be at the Marriott Lexington Griffin Gate Golf and Resort and Spa in Lexington on June 28th. You are certainly all invited. Please look for information on our website. We also have an annual meeting at the Seelbach Hotel in Louisville on solid tumors to follow up from ASCO later this year. That will be on October 18th. We hope, as I mentioned, to do this again in 1 year's time, so please take a look at that meeting as well. Before we adjourn, CME reminder for everybody. You can find the QR code here to take you directly to the website. You'll also get a reminder email after the meeting. Be sure to pick up your to-go lunch as we're trying to be efficient today and get everybody out on time. And again, thank you very much for your great comments, your contribution coming out, and please let us know if there are things we can do better. Thank you all.